it's under the Ministry of Employment and Labor, the Korean Occupational Safety and Health Agency, the KOSHA, which I thought was funny. And so the industrial accident rate in 2011, they did some background. So 2011, they had 65 per 10,000 workers, and about the same in 2021, 10 years later. Similar with deaths, but what I thought was interesting was when we get down to the worker compensation benefits, although the numbers were similar, the money spent on those benefits almost doubled, basically. They don't really talk about why, and we could speculate, but that's not really the point of this paper. And it stopped working. Well, I should use this. Maybe. Oh, no, I think that it's the Zoom thing up here. Sorry, technical difficulties. How do I get the mouse, Bubba? When you started recording it, the pop-up blocked me. There we go. And we're back. Okay. So workers' compensation process, they went kind of through the process, and it was hard to follow completely. There were not a lot of details. So they said they had an injury and then were given medical treatment. And when that medical treatment was over, they, if indicated, would have long-term care and rehab, which felt like it was very separated from the medical treatment. Whereas for us here, it's generally you have the injury, you get medical treatment, and that continues until it's not needed anymore. And potentially you go and get more treatment if it flares or aggravates later. But this felt like very separate things. But again, they didn't really do a lot of specifics. But medical treatment takes place at a designated facility. And I don't think in this case is associated with their on-site first aid that they talk about, that we'll talk about in a second. So the primary objective of the study to investigate the percentage of on-site first aid provision in the event of industrial injury. They excluded diseases. There's injury versus disease in occupational medicine. Injury is generally just an acute issue that happens one day, whereas occupational disease can be prolonged or chronic, or different sets of symptoms, perhaps. But other objectives, they wanted to see how on-site first aid is related to utilization of healthcare in the future for these patients, and whether transfer time from the accident site to medical institution was pertinent. So this was a retrospective longitudinal study. They started with 3,092 people, injured workers, mostly males, and all of these people had their medical care terminated in 2017, and then they were, this longitudinal study looked at the next 4 years, from 2018 to 2021. And they used this panel study of workers' compensation insurance data, which I think we have some similar databases here in the US, but they looked basically at the Korean workers' comp insurance, which I think is more centralized for them, but is about the insurance coverage and socioeconomic characteristics and things that will result in some limitations because it doesn't have a ton of detail. But it's all after termination of medical treatment, which again is a little confusing when you read the paper, because you say, okay, well, medical treatment, and they talk about duration of medical treatment, but then they don't really talk later about like, well, recurrence and things like that, and how that measures up. So it's a tablet assisted personal interviews. So of the 81,000 people who terminated medical treatment for industrial injury in 2017, they included 3,200. 202 of them were excluded due to incomplete answers, and they used proportionally stratified random sampling, and, as well as some systematic sampling. In 2018, they used the on-site first aid and disability level and duration of medical treatment. I'm not entirely sure why they differentiated it, since all these people were supposed to have had their medical treatment terminated in 2017, and so this was a little, again, vague and confusing. But basically, from 2018 to 2021, they took these people and looked at disability level, whether or not they got on-site first aid, as well as a host of other covariates, including hospitalizations and number of outpatient visits. So when they were asking the question, did you or did you not receive on-site first aid, yes or no? What is your history of visiting medical institutions in the past year? And that was self-reported, as well as how long did it take for you to be transferred to the medical institution. So all of these things, these key indicators, are unfortunately self-reported, and so are then subject to human error, right? So the covariates they looked at: sex, age, education level, economic activity, household income, area of residence, medical histories, types of injuries, disability grades. They had 14 levels of disability, which they split up into about 6 different categories, 1 to 3 being the most severe, which didn't feel like they should. I felt like it should have been 14 was most severe, but whatever. Period, and that's probably, maybe that's just an Americanism also, but also period of medical care. They used for statistic analysis a generalized estimating equation, Poisson regression, which when they talked about their analysis, I had a very hard time with my level of statistical understanding, knowing what they were talking about. Even with a little bit of Googling, I struggled. So they were like, log link function, an unstructured working correlation matrix, lowest quasi likelihood under independent model criterion. And that means very little to me. But we'll talk whether or not that was appropriate, with potentially some input from you guys who know a little bit more about that than I do. But they hadn't adjusted their data that they looked at in the end was an adjusted relative risk with 95% confidence interval. They reported no evidence of collinearity, used SAS with a p-value of less than 0.05. So the results were kind of in a portrait fashion, so I'm going to have various slides with the tables just so we can see it better. But table 1, we saw more people got on-site first aid than not. Definitely a lot more males than females. And the highest number of people who got injured were in their 50s. I had to look up what economically inactive meant, and that means that you're neither employed nor unemployed. Basically, you're not looking for a job. So that could be being a student, being a stay-at-home parent, those kinds of things. And so the majority apparently were economically inactive from 2018 to 2021, because they had to have been employed during 2017 when they got injured. Otherwise, they wouldn't be included in this data. The quintiles for household income, they did not talk a lot about, but there's the most of the people in this were middle quintile, as well as a fairly even distribution of metropolitan versus provincial. And some other, I mean, this is just the demographics for it, so we don't have to go into too much detail. But Disability grade, they talked specifically about fracture being the most common, and that disability grade 1 through 3, there were very few of those, which is the worst set of disability. The medical treatment, more than a year, were also the least. So not a ton of severe injuries compared to the numbers of the others. So table 2, let's see, sorry, I just want to move this out of here. The regression demonstrated the relationship between the on-site first aid and healthcare utilization. So we're looking at no first aid versus on-site first aid and the different years. So participants who received on-site first aid visited outpatient clinics about 16% less frequently per year than those who did not. Up over here. So the adjusted relative risk was 0.838 for those who received on-site first aid. And then they compared it to 2018 for the following year. So compared to the year after the medical treatment termination, the number of outpatient visits was significantly lower. Looking at the confidence intervals, you have protective seeming relative risk there. And then for household income, the significant relative risks were for the second and middle quintile, as well as with chronic disease. So those with chronic disease were at a higher risk of I just lost my train of thought. Sorry, guys. Anyway, they're at a higher risk with without the on-site first aid. All right, moving on. So the lower the disability grade, the lower the number of outpatient visits. So they were using the number of outpatient visits kind of as a healthcare utilization. It felt like they were implying that, well, we'll talk about that in a second, but especially with no disability. So the having no disability there, as well as that grade 13, 14, that lowest grade, were the most were significant and the most protective for healthcare utilization. So basically using less outpatient visits. And then the period of medical treatment, those were both significant. Having more than 3 months essentially of treatment resulted in, well, potentially resulted in higher risk of having more outpatient visits over those next 4 years. So table 3, subgroup analyses based on covariates. These are the highlighted ones are the significant differences there. And so in 2021, only in 2021, so 4 years after medical termination, they had significantly less outpatient visits, as well as males and those over in their 50s or over, or in their 50s, I guess, and then those with high school graduation or lower. And so those all had less outpatient visits when adjusted for those covariates. Same with unemployed and these quintiles, as well as living provincially. And so we'll talk about kind of what maybe we can glean from what those mean. But in your 50s, male, living provincially, and being employed, all things that potentially have you seeing a doctor less. And the thing to know about the outpatient visits that they're calculating is that those outpatient visits were for any reason. They did not specify why they were going and did not have that data to look at. So rupture and laceration was the only significant one with a significant difference as far as type of injury goes, as well as no disability, and period of medical treatment being less than a year, after adjusting for all those different things. So this one looks at detailed effects of on-site first aid based on transfer time. So when they got injured and received first aid to when they got transported to a medical facility. And the only one with significance was less than a half an hour. So people saw less, or people went to less outpatient visits if they'd been transported in less than a half an hour from receiving that first aid. So on-site first aid, there's 16% less outpatient visits over the next 4 years, but only with that less than 30-minute transport time. There were decreased visits with men over 50 in poor rural areas. In those rural areas, are there less medical resources? Is it more difficult to get to the doctor? Is it those men over 50? If I had to stereotype, I'd say that men over 50 are probably more resistant to going to the doctor. But the quote from the paper: first aid significantly reduced the number of outpatient visits for industrial injuries that did not result in permanent disability with less than 12 months of treatment. And they consider that mild injuries. So they said first aid significantly reduced, and I'm not sure we can say that because that's more of a causative statement, it seems like to me. It does suggest, their data does suggest that, right? But also, they're mild injuries, so who knows? But like I said, too strong a statement. Could it just be they didn't need more visits with lesser injuries? It does suggest possibility they talked about of first aid being poorly rendered, or not being effective with severe injuries. And then ruptures and lacerations were the only one that showed a significant difference in outpatient visits after first aid. So all the others, you could posit that it doesn't matter as much. And lacerations, cuts, bleeding, that kind of thing, it is somewhat is easier to provide first aid for, it feels like, because you can stop it and bandage it up, right? After covariate adjustment, there's significantly less outpatient visits with someone who got first aid, and hospitalization and count duration were unaffected. So they didn't really talk a lot about the hospitalization. So conclusions: receiving first aid, their conclusion was that receiving first aid for reducing healthcare utilization after medical treatment is crucial. And so therefore employees should receive first aid training, especially for ruptures and lacerations. That rapid access, especially under that 30-minute threshold, is crucial in a range of medical conditions and may be significant, and implementing that kind of as the golden time limit. And they did mention that it's similar to US studies that have been done on certain similar things, and that 30 minutes or less is a pretty good number to look at. Possible that participants who had a higher tendency to seek healthcare utilization have requested on-site first aid following industrial injuries. So somebody who's willing to go to the doctor more, or who's willing to, it could be a selection bias, I guess, is kind of what I'm thinking. And then the Korean industrial injury system is kind of loosely based on the US system, it looks like. But me not really knowing specifics and them not explaining a whole lot about it, it's hard to tell generalization. So strengths, it's upwards of 2,000 plus, seemed like a pretty decent amount. They had 84% compliance, and so they didn't get rid of too many by the end. And controlled for multiple covariates. weaknesses. The self-reporting is an issue. Reasons for healthcare utilization specifically, like it felt like they were implying first aid means they'll not be using healthcare for that issue, right? But they weren't talking about that issue. They were talking about all issues, which, you know, medicine is very interconnected, so who knows? But that was not specified, and they acknowledged that. Coworker first aid is what was provided, and so that's extremely variable. And then we already talked about potential generalization. So there's a quality assessment. Don't need to go through that all line by line, but basically my assessment was that it was of fair quality. So not fantastic, but not too bad either. So major thing at the last few minutes, does the data qualify, do the data justify the conclusions? What do we think?
For me is to, what was the purpose of what they were doing? Were they doing it as a safety professional saying, we don't want people getting a higher level of care, we're trying to keep things in-house? Or were they doing it from the lens of a medical professional saying, we're trying to not have our ERs overcrowded or not have our doctor's offices overcrowded? And I'm having trouble understanding which lens they're trying to look at it at. So if it does conclusion, I wouldn't think so, because it's just too ambiguous as to why they're going to the doctor, because it sounds more like you're looking at the medical side rather than just the safety professional side.
It seems like they're trying to decrease the amount of healthcare utilization across the board, and saying, like, you know, does providing first aid for these things do that? And they think tentatively yes.
I think another lens coming from Korean OSHA. And they're probably wanting to decrease what they're paying out. So I don't think it's either the safety professional or a provider necessarily. I think it's the insurance companies being like, we want to pay less. Does first aid help us pay less?
And piggybacking on this, it's kind of occupational health and safety really rose in prominence on the policy agenda of Korea in recent years, because there was kind of like a run of a lot of deaths. And so I think the government's been throwing a lot of money at it. So you see a lot of papers out of Korea that are kind of along these lines. So it might be more of like a policy audience sort of thing.
So my concern here with, you know, the data justifying the conclusions is the record bias. It all depends on, you know, what we remember. And also, I read somewhere in the article that it says they counted all the hospital or the medical visits without, you know, identifying the reason. So maybe for a different reason, they went for a different reason, and it still counted as a usage of the system, which is another, like, you know, big flow. I mean, I don't think I don't agree that the data will justify the conclusions.
You know, if they looked at first aid that didn't require anything afterward, like someone got hurt at their workplace, they did first aid and just never became like reportable.
I don't know. It seems like not.
You're talking about the data set. It was a data set where selection into responding to that survey was contingent upon hospital care.
Yeah,
Which would be an interesting thing to look at from a different lens, because like if they're trying to reduce that healthcare utilization,
right?
wouldn't you want to see how many people actually had it not ever even get there?
Yeah,
because then you could find out, is it worth having someone who has some EMT training or something on site at places with high injury rates that we can just decrease hospitals altogether.
So a couple things about this. The study feels like weather reporting. Like it didn't really have a very strong statement. This is why we're doing this, or this is the relationship we're curious about, or this is our hypothesis, you know, which we teach you guys not to do stupid things like that. You should have a reason for doing the crap you're doing, whatever it is. Why are you doing that? You should have an answer to that question, right? I tell my kids that, but I also in research, we really should have a research question. And I didn't really feel like they had a very strong one. So it meant to me that the study is designed and implemented and provided so that way whoever needs to use a bit of information for whatever the purpose might be, they can say, well, these guys showed that blah, 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 right? And so from a Korean OSHA perspective or whatnot, they can point to this as a scientifically valid study to justify changes they might want to make to the compensation, policies and practices related to, injuries in the workplace, right? So that's one thing. The second thing is recall bias. I don't know if you guys know the origins of that, but in 1885, so this goes back a long way, Hermann Ebbinghaus created a mathematical model or formula for understanding how humans forget stuff, right? And he proposed, and it's been validated many, many times since then, which is really kind of remarkable. It's almost a law in the psychology of learning that after 3 days, unless you do something to deliberately retain the information, like studying, which is why we teach kids to study all the time, you lose 70% of what you saw or heard, experienced, etc. Right? So if you don't, after you have a class, rehearse that by reading the book or looking at the PowerPoints or studying, you lose a lot of that, right? And so when you think about the recall bias issue, if you are asking these questions and you're saying, did you get injured in the last 12 months? Well, they can't remember they can remember 30% what happened 3 days ago, right? And you want to see if they remember that one time 8 months ago where they tweaked their back a little bit. They might remember that if it affected some other things and they made those neural fiber connections and retained that information, but more than likely, they don't even recall it at all, right? So it's just really messy data to then be used to draw whatever conclusions you want.
We were running out of time here, but we've got several online comments and questions.
Very good.
Yeah, it's great. I encourage that every week.
That's what everybody is.
A comment from Chapman says, this seems like a pretty weak analysis or finding to prove significant differences, especially if they're trying to change a bigger systemic policy. They're going to have to present this to higher up individuals, and the results of the analysis do not seem strong enough to overshadow some of the shortcomings when it comes to bias in data selection and collection. So that's just a comment. A question from Micah to you, Karl. Do you think that the overly strong causal statement about first aid reducing medical visits suggests some connection or bias with researchers being incentivized to find a certain result, like an insurance company paying for a study or something along those lines?
I mean, I would not be surprised. It's not paid for by the insurance company, but it's possible that the insurance company in Korea is heavily associated with the government and OSHA and whatever. So I would not be surprised if that's the case. But it's also possible they just wanted the answer to be a certain thing, and therefore they went with that, which that's what the data says. So this has got to be causative, right?
Time-wise, we put it off there and switch to Quinn.
blame it on Karl. Thanks. Population was you had to have image verifying some sort of a partial thickness tear. That's how they established whether it was full thickness or partial thickness. So it was either MRI or ultrasound verified injury. And it was, there's 4 tendons that compose the rotator cuff. The most common of that is the supraspinatus tendon. And that's the one most commonly injured, I should say. And that's the tendon that they specifically were looking for tears in. The purpose of the study was defined as, well, they wanted to perform a randomized controlled trial. They wanted to compare PRP with the current standard of corticosteroid injection, and their outcomes, they're assessing pain and functionality by 2 different metrics that we'll go over more. And their hypothesis was that PRP would provide improved pain relief and improved function in patients with partial thickness tears when compared to corticosteroid injections. So a little bit on their background, they said, listen, everyone has rotator cuff tears, or it's quite ubiquitous, which is true. In clinic, we're always cautious to get imaging because yes, they might have them, but no, they might not be clinically correlated or clinically relevant. But regardless, a lot of people do have rotator cuff pathology. Surgery, just to kind of throw it out there, is typically reserved only for full thickness rotator cuff tears, which is why they're distinguishing partial here. And then they kind of hinted at the fact that corticosteroid injections are not really aimed at the pathology or promoting healing of the injury. So they were hoping to maybe focus the light more on prevention and healing of a partial thickness tear. And ultimately, kind of what they're insinuating is preventing that from progressing to a full thickness tear. So some more background. Corticosteroid injections are first-line treatment. They are kind of what we would call like a standard. That is not the only treatment. There's a lot of other things like physical therapy, increased physical activity, NSAIDs, all those as well. But they are essentially a first-line treatment. This, like I said, is symptomatic though, so it's really assessing pain. It's not attempting to promote healing. The one slight caveat there is in our occupational medicine clinics, we'll use a corticosteroid injection in the setting of a patient who is concerned that they would not be able to tolerate physical therapy. So that would be a good indication of improving pain to get them to physical therapy, because physical therapy is actually the treatment that's going to get them better, not the steroid injection. And the PRP, or the platelet-rich plasma, is a biologic treatment. I'll go over the specifics of how it's obtained. It comes from the patient themselves at the time of the visit. And basically, you draw whole blood, you centrifuge it down, and then you return products that are without the red blood cells to the patient at the site of injury, which does increase local platelet concentration and a whole host of growth factors, which have been associated, or the thought is that this could potentially increase healing to the site. But overall, platelet-rich plasma is quite controversial. There's not a ton of data out there, which is why this study was so interesting to me personally. So this is how it's done. So you have a patient come into clinic, you draw their blood just like any lab draw you guys have had. You have a tube of whole blood, you put this in a centrifuge, you spin it down. We're looking for the purple layer there. The whole blood, the red blood cells go towards the bottom, and the plasma goes towards the top, but the platelet-rich plasma is more dense, so it goes between. So you then extract that. Again, patients, you're doing it in the room with the patient. It takes about 15-20 minutes. Probably a little bit less actually. And then if you have a rotator cuff injury, like in this study, you would use an ultrasound to identify exactly where the needle is going and exactly where that injury is. And then you would inject this platelet-rich plasma at that site with the thought of introducing more platelets, growth factors, everything to promote healing. So the methods. This study assessed a total of 382 patients. Ultimately enrolled 104. I'll go into that a little bit more detail later. Their inclusion and exclusion criteria. This is a little bit of an information dump, but you had to be 18. Like I said, you had to have image verified injury We'll hint on this later, but it's tendinopathy or partial thickness rotator cuff tear. Tendinopathy was never defined, which is one of my problems with the study. You had to be symptomatic for at least 3 months. You had to have gone through adequate non-operative treatment. And some of those things I mentioned before, NSAIDs, home PT, other injections were also included, but not more than 3, and not within the last 6 months. No previous shoulder surgery at the shoulder of injury, no full thickness tears, no arthritis in the shoulder that's hurting, no cervical neck pain or radiculopathy. My thought is they're probably just trying to eliminate confounding here. And no elite level athletes, again, not defined, and no workers' comp patients, and no patients with cases that were either had been or currently undergoing litigation. So their outcome, their primary outcome was assessing pain, which is a little bit different than what we do in clinic. We try to avoid pain and focus on function, but fortunately that was their secondary outcome. They had 2 ways to do this, 2 scales. I had honestly, full disclosure, never heard of these scales before, but I looked them up and I'll show them to you in the next couple slides. So pain and function were assessed at screening at baseline, as well as 6 weeks, and then 3, 6, and 12 months. They used block randomization to identify their 2 treatment groups, and it was double-blinded. So the treating physician or treating orthopedic surgeon and the patient were blinded. It was not triple-blinded. So the actual physician who was administering the medication under guidance of ultrasound knew the treatment groups. So they were not blinded to that. So this is the primary outcome measure. So this is a visual analog scale for pain. You guys probably are familiar with this. It's in every exam room, or most exam rooms now. I used to work in the ED. We used to use this all the time. It was really helpful. How are we doing? Are we treating pain or not? Is it less? Is it more? It's great for kids, actually, because they point out the smiles really easily. But it's kind of a taboo thing in occupational med clinic, especially our clinics. We don't honestly care too much about pain. We try to avoid patients from thinking about pain, but we want to function. Are you returning to work? Can you do your job? Can you do your daily tasks? Can you do what you're passionate about? How is your life quality from your functionality, not so much from the pain? So these are the metrics that they use to assess that. The American Shoulder and Elbow Surgeon Score, it's 17 questions. I included a couple screenshots here. General info about work, talks 1 question about pain, and then 3 categories: somewhat difficult, very difficult, or unable to do it. And then there's a task. So like number 8 at the top, is it difficult for you to put on a coat? That was assessed, like I said, secondary outcome at those time intervals, as well as the Western Ontario Rotator Cuff Index. Very similar. This is 21 questions. This is 1 section. There's probably 6 sections, including like emotional questions, work questions. But how much sharp pain do you have? And there's no pain to extreme pain. Now, the patient, from what I read about it, they just put a mark on here. So I'm not exactly sure how they quantified this, if they measured it and walked it out, or if there's supposed to be numeric indicators on here. But that's just 1 question I kind of had. Yeah, you can do it online. And it'll automatically quantify it. Yeah, it was. They just said self-reported, like by the patient, and I'm not sure if it was online or paper. Hopefully online. Yeah. So moving on to a little bit of the data. So it was powered to 80%, which is what we like to see. Assessed. So this was confusing to me. So assessed the minimum clinical important difference in their primary outcome, this VAS pain scale. But after I read it 3 or 4 times, I finally grasped it. They're just saying that pain scale, you can actually quantify how long it is, and if it's 10 centimeters, they're saying they're trying to get away from statistically relevant data varying from clinically relevant data. So they're saying, We want to focus on something that's clinically relevant, which is great. And a pain score of 1.4 is the first level of clinical relevance on that pain scale, 1 through 10, if you made it 10 centimeters. So they're just saying, you know, a little bit of pain, we saw that it was 1.4. That's when it's clinically relevant. That's what we're trying to focus on. We're not trying to split hairs statistically and find something that is an actual pain scale that's statistically different. We're trying to keep it clinically relevant. It was a strange point, and they keep focusing on it, but I appreciate the effort. There were 2 treatment groups. There was a corticosteroid injection group and a PRP group, a 52 in the corticosteroid group ultimately, and 47 in PRP. I'll discuss how we got to those numbers a little bit later. Yeah.
Claudia's wondering how many injection sites PRP. Was there just one like the corticosteroid or was there more?
So there would have been, so everyone had blood draws to try to eliminate knowing which treatment group you're in. So it was either blood that was drawn and then centrifuged, or blood that was drawn and then discarded. And then after that, there would be 1 injection for each, the corticosteroid and the PRP groups. And then failure, I'll talk about it, but I can bring it up now. Failure of the treatment was seen as the patient requesting another injection. So at time of treatment, 1 injection. There were, let's see, they just said that they matched the 2 groups. So there was no difference in age, sex, tear etiology, or duration of symptoms between the 2 treatment groups. A little bit of statistics. They used the Fisher-Exact t-test to, well, they said they used cross-tabulation analysis to assess baseline characteristics, and then differences were assessed using the Fisher-Exact t-test. And they used the independent samples t-test as well to look at changes from the baseline outcome scores on those 3 metrics that I went over, pain and then 2 for function. And they indicated they used cross-tabulation analysis to assess failure rates. And then this is kind of where I go into it. Failure is defined as either obtaining surgical consent, getting surgery, or asking for an additional injection. So this is where we kind of get down to the groups. This is figure 1 in table 1 if you wanted to follow along, but ultimately they interviewed 382 participants, 70 declines, so they're left with 312 potential participants. 208 were excluded, leaving 104, which they randomized between the 2 groups. The corticosteroid group, through treatment, either lost a follow-up or incorrectly, I think 1 was incorrectly identified as a partial thickness tear. Anyway, they excluded 2 from the corticosteroid group and excluded 3 more from the PRP group, ultimately arriving at 52 in the corticosteroid group and 47 in PRP, and the male-female demographic is listed there, more females than males. So one interesting thing, which is in table 3, that's my next slide, is that despite this randomization, this block randomization, there were statistically different findings of the baseline PRP group. They reported more pain and less functionality, which is strange. It seems like we can talk about it, but that's my first question to you guys is why? I honestly don't get it. Why, despite the randomization, unless the randomization was inadequate, this would happen. Double-blinded, so it was patient and prescribing physician, not administering physician.
During the randomization.
I don't know. They didn't say.
Any knowledge by someone who is putting people in groups.
It seems like there was, but I don't know.
And if there was, that could explain, I mean, any number of random things could explain a difference there, but this one smells a little funny.
Definitely. So overall, outcomes improved for both interventions at the vast majority of time points, the only exception being at 3 months, the corticosteroid group did demonstrate a statistically inferior result to PRP. So there were no difference in failure rates between the 2 groups, and there were no adverse events. So this is the table I was talking about. Look at the red circles. So you got top, baseline 6-week, 3-month, and 12-month. So we are seeing, and it's not even borderline, I mean, significant p-values for more pain, less functionality in the baseline randomized PRP group. That's a problem. So then, as far as the study results go going forward, they were statistically significantly improved in less pain, more function in the PRP group at 3 months, but that was lost at both 6 months and 12 months. So just that one time point. This more or less says the same thing. This is looking at 12 weeks or 3 months, saying that here we do have statistical significantly different results between the two groups. But other than that, there was an overall trend in improvement in symptoms and functionality. This is just the last little result. I didn't mention this, but they did do repeat imaging. So at 3 months and 12 months, they took an ultrasound, looked at the partial thickness tear that had been there or the tendinopathy, and they assessed whether or not that had progressed. And it had in a very small number of patients. So 2 of the corticosteroid group and 1 of the PRP at 3 months, and then respectively 3 and 2 ultimately. Just trying to see if there is a major difference in who progressed and what may have been going on there, but it was pretty small. So the major finding here was that patients demonstrated decreased pain and increased function in both groups. The PRP group at 3 months experienced, like I said, superior results in all of the scores, actually. So less pain, better function, self-reported function though. And the benefit in the PRP group was lost beyond 3 months. Their next time point was 6 months and 12 months. Then in their discussion, they hit on they hit on 2 meta-analyses. And I did want to bring them up because this kind of gets to my last point on this slide. So the first meta-analysis, Hurley, indicated that PRP injections were not effective for short-term improvements in patients with partial thickness rotator cuff tears. And the authors kind of pushed back and said, well, hold on a minute. Major shortcoming is that they did not report the PRP preparation, exactly how this was done. Okay, and then they just said also they had bias, and that was it. Which I tend to get strong opinions when I read these papers, and I'm trying to hide. I'm literally being a hypocrite and doing what I'm saying that they did, but I was just like, come on, guys, you can't just say they had bias. If you're concerned, list what it is and why. So the second meta-analysis, they said there was no difference with corticosteroids at 3 months. And they said, hey, these guys are great, high fives. That's what we found. But ours is even better than this because we found that PRP was superior at 3 months. I mean, which is, to their point, true. I mean, it was a double-blinded randomized controlled trial. But overall, in the discussion, it kind of seemed like the authors were defending PRP and trying to find shortcomings with corticosteroid injections. One thing they said is corticosteroid injections were strongly correlated with rates of revision in cuff repair. First of all, yes, this is true. This is kind of old news. In clinic, if there's any concern for any possible surgery coming up, we don't give a steroid injection. Orthopedic surgeons want to wait at least, I mean, honestly, 6 months, 3 months for sure, but a lot of them won't touch them for 6 months. So this is very well established. This is very well known. And also it was a little confusing because they're saying this is kind of assessing corticosteroids in the setting of surgery when the whole paper is actually not focusing on that at all. They're saying we're trying to get this earlier, prevent progression to full thickness tears, and give non-surgical options. And then they also went on to say that there were a few reports of adverse effects of PRP injections in the literature. And that's, again, I feel like not giving a full disclosure because, of course, there are few adverse events because there's almost no literature on PRP injections. I mean, that's why we're doing this study. So yes, they're right, but at the same time, it's just not quite giving a fully representative statement, in my opinion. So weaknesses of the study. Some of these are from the paper. Actually, most of these are, but some of these are also from me. So there's variability in the PRP preparation. As I said, this is done on each patient. When you do this, You don't know the volume of like platelet-rich plasma that you're going to end up with. Therefore, you don't know how much you're going to be injecting. You really haven't quantified any of that. It's not assessed, it's not analyzed. It's simply blood is drawn and put back into the patient. So it's a little bit hand wavy as far as details of what's happening there. Also, if you want to really split hairs with the PRP injections, there's debate on if we should use leukocyte or white blood cell rich versus poor solutions. There's no consensus. There's not even consensus on PRP injections, much less should you use rich versus poor. This study used poor, and they said we use poor because that's what we use at our institution and we don't want to change, which that's fine. But again, that's just one more consideration. We talked about it was not triple blinded. So there were two physicians who were administering these. They called them musculoskeletal radiologists. And which I guess is good. We only have potentially two people doing it, potentially two different ways. But that was not a triple arm that was blinded. Or sorry, that was not I guess, triple blinded study. And this tendinopathy, it's a very vague term. And I would have appreciated to at least know what they were considering tendinopathy in the study. It wasn't defined, and it was one of their primary criteria, tendinopathy or partial thickness rotator cuff tears. I didn't know if they were saying that was synonymous. They never, from what I saw, really addressed that. And then this is a big one to me. They did not restrict or enforce participation in physical therapy. That's huge. So like I said, in our clinic, we'll use corticosteroid injections if we think they're going to have difficulties progressing or performing or going to physical therapy. So to not control the greatest potential influence on their course of disease is kind of wild. So to me, this definitely could introduce a lot of confounding. And although they said the sample size was a strength and they called it a large sample size, it was right around 100 people. I'm going to call that small and say that was a weakness. So strengths, though, it was, like I said, experimental design. We kind of talked about only 2 people administering the injections, and they did adhere to their strict inclusion-exclusion criteria. And the paper, again, identified a long 12-month follow-up. I wouldn't say that's long, but it's adequate. I appreciated the full year, but I would have liked to see more. Some of the limitations here, obviously this difference of their baseline randomized groups. That's strange. I hadn't seen that before. So that potentially the author said could have introduced confounding. Let's see here, limited radiographic follow-up. So they're just saying that it wasn't an MRI. It was an ultrasound, and we can't assess a lot via ultrasound. We can tell if it's partial versus full thickness, but we can't tell healing process. They just said we would have liked to have more detail on the tear following the administration of these 2 interventions. This is another big one for me. So there was no sham group. There's no control group. There's no saline injection, which I'd love to see, because previous studies, the placebo effect is quite strong and has shown improvement in this type of thing with simple saline injections. So I think not having this is actually a really large downside. And the funny thing about it is when they said they tried to defend why they didn't do this, and they said they were concerned that their enrollment would suffer. So basically how this happens is you're in clinic, you're pitching to someone, hey, do you want to join our study? They say, yeah, sure, what's it about? And you say, well, we got this new cool treatment, PRP, or we're going to use the gold standard of care, corticosteroid, or you might get nothing. And they thought that if the people hear, oh, you might get nothing, they're not going to do the study. So they kind of didn't do it out of fear, which is strange and weak in my opinion. Really weak, actually. So that was my final limitation. So that's really all I had as far as the article goes. I did appreciate, like I said, the experimental design. Sample size could have been higher, follow-up could have been longer, but there's just not a lot of research in this area, so it was a fun paper for me to jump into. A couple of shortcomings. But my big question, Dr. Allen, kind of jumped into already, which was the why would these groups be different? But if there are any questions, feel free to voice them or concerns.
Just a thought about the baseline difference, the significant difference between the two groups. I just like thinking this could explain a little bit the results. I mean, being in the group with like more severe pain, they have more room for improvement.
Yep.
Yeah.
So this is why they reported more improvement compared to the other group, especially at the 12 months, comparison, there was no difference. So I wonder if this is like, a big bias for the results. The second thing is, do we know who got the MRI versus the ultrasound?
No, they just said or.
And actually, I just like to think about inter-user variability for the ultrasound. The ultrasonographers may be like, different in their like evaluation. So I don't know if this is also introducing a bias in the.
Yeah, that was my concern with who was doing the injections, and they did a pretty good job with only having 2 people perform the injections, but not the assessment phase, because they didn't limit it. They didn't say that those 2 physicians were necessarily the ones that were assessing via ultrasound as well. So I believe it's probably just the classic, you throw an order in for an ultrasound, you go to imaging, and an ultrasound tech does it. So I think there's a lot of option for that.
Do you know if the injections look the same? Cause
Yeah,
I can see that being a really easy way to tell whether you're getting.
So just from performing them, no, they don't. Ones can be clear, a little foggy white, and the other one is more of an off yellow. No, they're not, they don't look the same.
Is it like a different amount? Like you said PRP is usually a very small amount of.
They hinted on that. It is in the paper, and I didn't go into that in my discussion here. But they did try to alleviate the volume differences, but they were different.
They had therapy in the paper and how that.
Yeah, so it was weird because they said in order to, an inclusion criteria was that you had to have considered other non-operative modalities, physical therapy being one of them. And it was very obvious they were all about physical therapy. They thought it was great. But as we indicated later, there was no, there's no way to follow who is getting physical therapy. And when they say physical therapy, that included both home exercises and formal physical therapy. So there's just all kinds of problems there. And then we don't even know who was getting it. And if they were getting it, what type of physical therapy were they getting? And like I said, this is really, physical therapy is what gets people better. If it's not, if it's full tear, well, it's probably not going to get you better, but it actually might. I think Dr. Hegman would probably argue in favor of that.
In this area, but there are 2 meta-analyses.
Yeah.
I mean, meta-analyses are, reanalyzing multiple studies.
Yeah.
Right. And they say, well, they're garbage, or at least one of them's garbage, and one of them was similar to ours. So I'm wondering, are any of these individual studies? Now I know you probably don't know the answers, but are any of the individual studies that were in those meta-analyses, do they do a similar, process? Do they do an RCT? If they do an RCT and they already showed it doesn't have an effect, this RCT that has a bunch, or attempted an RCT has a bunch of problems, we should probably go with that other RCT or one of those meta-analyses as our decision point.
Right.
Right. I mean, so
my Flash Journal Club article is one of them included, because I had the same question. I was like, hold on, I need to delve into this. What are we pulling in these meta-analyses? So they listed one of them. So I'm going to go over that in the next group. But you're right. I'm not familiar. And if there's a meta-analysis, clearly there's research. I think a better way for me to phrase that would be there's not a lot of consensus in the use of PRP, as opposed to there's not a lot of research in the area.
that produces PRP,
Right. Right.
Clearly, they're trying to, even their terminology in there is very much in favor of or supportive of the use of PRP, which again, that suggests the researchers had a bias. Now they did a double blind, but we're not clear as to how blind that double blind really was, given that the 2 groups were actually different to begin with. So just kind of a stinker.
Yeah, I agree. I know we're past time. Don't want to keep you guys, but yeah.
Hi, everybody.